So now we'll start the renal system of Pance Prep Pearls. Starting with diuretics, mannitol is the first diuretic. The mechanism of action is an osmotic diuretic, increasing urine volume by drawing fluid from intracellular compartments and increasing tubular osmolarity. Mannitol is freely filtered but minimally absorbed. The proximal tubule is the main site of action. So it's a big particle that has a strong gravity and resists the proximal tubule reabsorptive force. It's given IV as well because it has poor oral absorption. Mannitol has 4 indications: treatment of intracranial pressure, treatment of refractory increased intraocular pressure, and promotes diuresis in the oliguric phase of acute kidney injury. Increases excretion of toxic metabolites. Also, mannitol increases urine output within 5 to 10 minutes of administration. Adverse effects are pulmonary edema due to increased fluid shifts, hypotension, tachycardia, hypernatremia, and hypokalemia. Monitor the input, urine output, blood pressure, pulse, and electrolytes during administration of this. It's contraindicated if they're anuric, dehydrated, if they're having acute decompensated heart failure, or significant electrolyte abnormalities. Acetazolamide is next as a diuretic. The mechanism of action is a carbonic anhydrase inhibitor in the proximal tubule, leading to sodium and bicarb diuresis. Indications is to reduce intraocular pressure in glaucoma and secondarily to reduce intracranial pressure. It acidifies the blood in patients with metabolic alkalosis, and it also alkalinizes the urine. So it's good for stones of uric acid and cysteine, and also in ASA toxicity. It's a mild diuretic, and they can have altitude sickness as well. Adverse effects are a hyperchloremic metabolic acidosis due to the increased loss of bicarbonate, hypokalemia, sulfa allergies, kidney stones, especially calcium phosphate, numbness, tinnitus, and vomiting. Contraindications are severe kidney or hepatic. Next, loop diuretics. So that's furosemide, bumetanide, and torsemide. The mechanism of action of loops are strongest class of diuretic. They inhibit water, sodium, potassium, and chloride transport, as well as calcium and magnesium absorption across the thick ascending limb of the loop of Henle, leading to a dilute urine. They also increase prostaglandin synthesis, improving renal blood flow. Indications for loop diuretics are hypertension and edema, especially pulmonary or peripheral edema due to CHF, nephrotic syndrome, or cirrhosis. Also, they can be used to treat hypercalcemia and hypermagnesemia, and transidative versus exudative causes here. Adverse effects, they decrease electrolytes like hypo-K, hypocalcemia, hypomagnesemia, hypochloremia, and hyponatremia. But there's also dyslipidemia, ototoxicity especially with high doses, rapid IV administration or renal insufficiency for that ototoxicity. Sulfa allergy, importantly, acute interstitial nephritis, also a hypochloremic metabolic alkalosis, hyperuricemia, as it can precipitate gout, and hyperglycemia. So remember gout, DAN, diuretics, aspirin, and niacin. NSAIDs may decrease their efficacy as well. So it's important to know for the loops that ethacrynic acid is another loop diuretic. It is a medication similar to furosemide that can be used if a sulfa allergy is present, as it does not contain sulfonamide, and it's safe also in patients with gout. Associated with a higher risk of ototoxicity, however. So it's a trade-off: you increase ototoxicity but decrease risks of sulfa allergy if you use ethacrynic acid instead of furosemide. Thiazide diuretics are next. This is hydrochlorothiazide, chlorthalidone, and chlorothiazide. Also, there's some thiazide-like diuretics. That's indapamide and metolazone. The mechanism of thiazide diuretics are to block sodium chloride and water reabsorption at the early distal convoluted tubule, the diluting segment. This leads to diuresis and inability to produce dilute urine. Thiazides also decrease urinary calcium excretion. So the mnemonic for what thiazides do, what they increase rather, are GLUC, G-L-U-C. So glucose, lipids, uric acid, and calcium. Indications for thiazides are hypertension, those with no comorbidities, African Americans, osteoporosis, and elderly. Also peripheral edema, nephrogenic DI, not neurogenic. Neurogenic would get DDAVP. Also decreases this ability to produce dilute urine. Adverse effects of thiazides are most commonly hypo-K, hypomag, hypochloremia, but most importantly increases glucose, lipids, uric acid, and calcium. Hypercalcemia, thiazides are the diuretics most likely to cause hyponatremia as well. Sulfa allergies and metabolic alkalosis. Next will be potassium-sparing diuretics. These are spironolactone and eplerenone. So the mechanism is an aldosterone receptor antagonist in the distal cortical collecting tubule, increasing sodium and water excretion while conserving potassium and hydrogen ions. Indications are primary hyperaldosteronism, also known as Cone syndrome, heart failure, which decreases mortality, cirrhosis-related ascites, weak diuretic, used primarily in combination with a loop or thiazide diuretic to minimize potassium loss, and it's also anti-androgenic. For females, they'll get hirsutism. It also can be used as a treatment for PCOS. And remember, so it is decreasing mortality in heart failure, and remember that's also ACE-ARBs, beta blockers, these aldosterone antagonists, and nitrate only with hydralazine. Adverse effects of potassium-sparing diuretics: hyperkalemia, normal anion gap metabolic acidosis, also anti-androgen effects, gynecomastia, erectile dysfunction. Eplerenone is associated with a lower incidence of anti-androgenic effects. Also a note on amiloride and triamterene. The mechanism of these is similar still under potassium-sparing diuretics, but they directly decrease sodium channel activity in the cortical collecting duct, but do not affect the aldosterone receptor. Indications are hypertension, CHF, and importantly lithium-induced polyuria, not associated with anti-androgenic effects. So remember amiloride for lithium, and no gynecomastia with amiloride or triamterene. Adverse effects, of course, are hyperkalemia and a non-anion gap metabolic acidosis. So now to compare the different diuretics, we'll go down the line through a table of each of them. So starting out again with mannitol, the mechanism is an osmotic diuretic. Indications are intracranial hypertension. Side effects are pulmonary edema due to the fluid shift, and it's contraindicated in anuric patients. Acetazolamide, similarly, however, it's a carbonic anhydrase inhibitor in the proximal tubule, leads to mild diuresis, acidifies the blood as well. Indications are for glaucoma and intracranial hypertension, also for urinary alkalization and metabolic alkalosis. Side effects of acetazolamide are hyperchloremic metabolic acidosis, sulfa allergies, and kidney stones. For loop diuretics, furosemide and bumetanide and torsemide inhibit water, sodium, potassium, and chloride transport across the thin ascending loop of Henle, rather the thick ascending loop of Henle. It's the strongest class of diuretics, and increased prostaglandin synthesis, increased renal blood flow. Indications: hypertension, edema, hypercalcemia, and side effects and contraindications are hypo-K, hypocalcemia, hypomag, hyperglycemia and hyperuricemia, caution in diabetes and gout, ototoxicity and sulfur allergies, as well as AIN. Ethacrynic acid, similar to furosemide, diuresis in patients with sulfa allergy is the indication, and it can be used in patients with gout because it does not lead to increase in uric acid, but it is more ototoxic compared to Lasix. Thiazides, chlorthalidone, indapamide, metolazone, chlorothiazide, blocks sodium chloride and water reabsorption at the early distal diluting tubule, leads to diuresis and inability to produce dilute urine. Indications: hypertension, nephrolithiasis, nephrogenic DI, importantly. Side effects: hyponatremia, hypercalcemia, hypokalemia, hyperlipidemia, remember gluc, hyperuricemia, hyperglycemia, therefore caution in diabetics and gout, also sulfa allergies, and metabolic alkalosis. Potassium sparing, spironolactone and eplerenone, inhibits aldosterone-mediated sodium-water absorption in the cortical collecting tubule. Indicated for CHF as it does reduce mortality, also hyperaldosteronism too. Side effects are hyperkalemia, metabolic acidosis, and spironolactone causes gynecomastia, an anti-androgenic effect. Lastly, triamterene and amiloride blocks sodium within the cortical collecting tubule. Indications are lithium-induced nephrogenic DI. Side effects, hyper-K and metabolic acidosis. Next, nephrotic syndrome. This is kidney disease characterized by proteinuria, hypoalbuminemia, hyperlipidemia, and edema. Primary etiologies are minimal change disease, which is the most common cause in children, may occur in the setting of viral syndromes, allergies, or Hodgkin's disease. It's due to a loss in negative charge of the basement membranes, which promotes proteinuria. So it allows the positively charged particles to flow through. Also, another etiology is membranous nephropathy. This is most common primary cause in Caucasian males over 40. May be seen within SLE, viral hepatitis, malaria, and meds like penicillamine. Next will be focal segmental glomerular sclerosis in the setting of hypertension, heroin, and HIV. So HHH. Hypertension, heroin, and HIV for FSGN. Focal segmental glomerular sclerosis, and this is within nephrotic syndrome. Secondary etiologies are diabetics, most common secondary cause in adults, SLE, amyloidosis, hepatitis, Sjögren's syndrome, sarcoidosis, medications, infections, and malignancy. And remember, for those diabetics, you always get your ACR, albumin to creatinine ratio, to see if there's albuminuria. Clinical manifestations: generalized edema, especially periorbital in children, usually worse in the morning. May develop frothy urine, importantly, ascites and anasarca if severe. Anemia, DVT, loss of protein S, C, and antithrombin 3, plus liver production of more clotting factors. So we're losing protein, so the liver's job is to increase their albumin synthesis and protein synthesis. So in doing so, it also increases its production of clotting proteins at the same time. So they're hypercoagulable. Diagnosis in nephrotic syndrome: you want to do a urinalysis first. Proteinuria causing frothy or foamy urine is important, also lipiduria. On microscopy, importantly, you'll see the oval, Maltese cross-shaped fat bodies, fatty casts. Protein measurements: urine albumin to creatinine ratio, and a 24-hour urine protein over 3.5 grams per day is the gold standard. Hypoalbuminemia and hyperlipidemia you may also see. On renal biopsy, this is the definitive diagnosis and most accurate test, although it's not usually needed. On minimal change disease of a biopsy, you'll see no visible cellular changes seen on simple light microscopy, but you will see podocyte damage seen on the electron microscopy. This is a loss of fusion of the foot podocytes. Not usually needed. For membranous nephropathy, you'll see a thick basement membrane, and it's not concentric like good pastures. Management of nephrotic syndrome: glucocorticoids is the first line for minimal change disease. For focal segmental glomerular sclerosis, steroids are responsiveness is important determinant of prognosis. So for FSGS, you have to see if the steroids, if they're responding to them. Other immunomodulators can be used like cyclophosphamide, cyclosporin, or tacrolimus. Also for continuing management, edema reduction, like diuretics, thiazides, or loops. Also 1 liter fluid and sodium restriction. Proteinuria reduction, ACE and ARBs, and the reason why they help is efferent arteriolar dilation, reducing renal blood flow, GFR, and protein loss. Also hyperlipidemia, you want to do diet and statin therapy. Next will be acute gomeonephritis. This is immunologic inflammation of the glomeruli, leading to protein and red blood cell leakage into the urine. It's characterized by hypertension, hematuria, red blood cell casts, azotemia, and proteinuria, edema. So the etiologies will be listed from most common first, Iga nephropathy, also known as Buerger's disease. This is the most common cause of acute gomeonephritis. often affects young males within days, 1 to 2 days after a URI or GI infection, due to IgA immune complexes. IgA is the first-line defense in respiratory and GI secretions, so infections may cause IgA overproduction. A post-infectious glomeonephritis, most common after group A strep, 10 to 14 days after skin impetigo. Or pharyngeal infection may occur after any infection. Any type of strep infection you want to consider post-infectious. Classically, between 2 to 14-year-old boys with facial edema up to 3 weeks after strep with scanty, cola-colored dark urine, which is hematuria and oliguria. Also importantly, an increase in anti-streptolysin, ASO, titers, and a low serum complement. So a lot there. So after strep, kids 2 to 14 years old, cola-colored urine, increase in ASO titers, low complement, and remember any type of strep infection, even like impetigo or pharyngitis. Next, membranoproliferative or mesangiocapillary glomerulonephritis. This is due to SLE, viral hepatitis, hepatitis C virus importantly, hypocomplementemia, and cryoglobulinemia. So membranoproliferative glomerulonephritis usually presents with a mixed nephritic picture. Okay, rapidly progressive glomerulonephritis, RPGN, is associated with a poor prognosis as rapid progression to end-stage renal disease occurs in weeks to months. Crescent formation on biopsy, importantly, crescents formed due to fibrin and plasma protein deposition collapsing the crescent shape of the Bowman's capsule itself. Any cause of acute gomeonephritis can present with rapidly progressive glomerulonephritis. The following two only present with rapidly progressive: Goodpaster's and vasculitis, importantly. First, Goodpaster's is a positive anti-GBM antibodies against the type 4 collagen of the glomerular basement membrane, the GBM, in the kidneys and the lung alveoli. So the alveoli actually have type 4 collagen as well, so this attacks the alveoli, leading to that hemoptysis and the anti-GBM bodies in the kidney itself. Also, another cause of rapidly progressive is vasculitis, which is characterized by a lack of immune deposits and a positive ANCA antibodies, or ANCA. For microscopic polyangiitis, is the vasculitis of the small renal vessels. This is a positive P-ANCA. For granulomatosis with polyangiitis, which is Wegener's, this is a necrotizing vasculitis, and it is a C-ANCA. So polyangiitis, microscopic, is P-ANCA, and Wegener's is C-ANCA. Clinical manifestations: hematuria, which is hallmark, cola or tea-colored, also edema, peripheral and periorbital, fever, abdominal pain, flank pain, malaise, oliguria, due to acute kidney injury. On physical exam, there'll be hypertension. They may have that periorbital or facial edema, and peripheral edema too. For diagnosis, urinalysis is first. You'll see hematuria, red blood cell casts, dysmorphic red blood cells, also known as acanthocytes. Importantly, proteinuria, usually under 3 grams, however, not over the 3.5 as we've seen in nephrotic. So under 3 grams, but can be in the nephrotic range as well. But you're also going to have these other signs too. High specific gravity, over 1.020 osmoles, and increased BUN and creatinine as well. The renal biopsy is the gold standard, but mostly not needed. In IgA nephropathy, IgA mesangial deposits on immunostaining. For post-streptococcal, you'll have the hypercellularity, increased monocytes or lymphocytes, and immune humps of IgG, IgM, and C3. Goodpasture syndrome, linear IgG deposits in the glomerular basement membrane. For management, it's usually self-limited with a good prognosis, except, of course, for the rapidly progressive forms. For IgA nephropathy or proteinuria, do ACE inhibitors plus or minus corticosteroids. For edema, hypervolemia, or hypertension, do loops or beta blockers or calcium channel blockers for hypertension. For post-streptococcal, do supportive, maybe antibiotics. For lupus nephritis, steroids or cyclophosphamide. For rapidly progressive or severe, corticosteroids plus cyclophosphamide. Now just to use this chart to compare side by side nephrotic versus nephritic syndrome. The pathophysiology of nephrotic. So first we'll list nephrotic and then nephritic for each category. Pathophys, nephrotic, glomerular damage leads to increased urinary protein loss. Nephritic, immune-mediated glomerular inflammation, leading to increased urinary protein and red blood cell loss. Hallmarks of nephrotic, proteinuria, hypoalbuminemia, edema, hyperlipidemia are all hallmark. And nephritic, proteinuria, hypertension, azotemia, oliguria, hematuria, red blood cell casts are hallmark. Clinical manifestations, edema for nephrotic syndrome is the predominant feature, peripheral and periorbital, especially in children. Increased BUN and creatinine, which is varying. Dyspnea, transudative pleural effusion, remember. DVTs, and frothy urine. Remember, transudative pleural effusion, most common cause heart failure, but also nephrotic and cirrhosis. For nephritic syndrome of clinical manifestations, hematuria, hypertension, azotemia, oliguria, fever, abdominal pain, and flank pain. They may have edema, but not as much as nephrotic. On urinalysis of nephrotic, proteins over 3.5 per day. Urine dipstick protein 3 plus or 4 plus. Also importantly, fatty casts, oval fat bodies in a quote-unquote Maltese cross. For nephritic, hematuria, red blood cell casts, usually less than 3.5 a day grams of protein. Biopsy of nephrotic, hypocellularity. Also minimal change disease, normal on light microscope, loss of podocytes on electron microscope. Associated with a loss of negative glomerular basement membrane charge, which further facilitates albumin loss, as albumin has a negative charge. For nephritic syndrome on biopsy, it's hypercellular. You have an increase in white blood cells and mesangial cells, also immune complex deposition, and crescent shapes of the glomerulus on biopsy show rapidly progressive glomerulonephritis. And remember, mixed nephrotic and nephritic picture, you'll have the hematuria, which is hallmark for nephritic, and nephrotic range proteinuria over 3.5 grams per day. Next will be acute kidney injury, acute renal failure. So we'll go into pre-renal failure, post-renal failure, and intrinsic renal failure. So this is a combination of a few things. Increased serum creatinine over 50%, or an increase in BUN to creatinine ratio, azotemia. The rifle criteria, 3 progressive levels of AKI. Risk, injury, failure with 2 outcomes determinants, loss in end-stage renal disease. So the phases of AKI, first oliguric, maintenance phase, urine decreasing output of under 400 mLs per day, azotemia, hyperkalemia, and metabolic acidosis. Then progressing to the diuretic phase, increase in urine output, hypotension, and hypo-K, and then to recovery. So the 3 types, pre-renal, post-renal, both are rapidly reversible, or intrarenal, which is intrinsic to the kidney itself. First, pre-renal. Pre-renal is characterized by decreased renal perfusion with nephrons still structurally intact. This may lead to intrinsic injury, acute tubular necrosis, if not corrected. Most common type of AKI overall, 40 to 80%, but ATN, most common type in hospitalized patients. Pre-renal etiologies are a reduced renal perfusion, which is hallmark, hypovolemia, renal volume loss from diuretics, GI losses like diarrhea, vomiting, or blood loss. Also afferent arterial vasoconstriction, such as in NSAIDs, which is why they're bad for kidneys, and IV contrast. So NSAIDs, including ASA, afferent arteriolar vasoconstriction, and efferent arteriolar dilation, like ACEs and ARBs. So ACEs and ARBs dilate the efferent arteriole. Not all the blood is rushing past the nephrons instead of going through them. Also hypotension, relative hypovolemia, such as with CHF, with a decreased pump function. For diagnosis of pre-renal, it is evidence of water and electrolyte conversion. So increased BUN greater than increased creatinine. So BUN to creatinine ratio over 20 to 1. Also a fractional excretion of sodium, the FeNA, is under 1%, and the urine sodium is under 20. Concentrated urine, high urine specific gravity, over 1.020, and increased urine osmolarity over 500. So the sodium and the water are all being held into the system, so it's going to be extremely high osmolarity in the actual urine. Management: volume repletion to restore volume and renal perfusion, rapidly responds to treatment. Post-renal azotemia will be next. This is also known as obstructive uropathy. The pathophys is characterized by obstruction of the passage of urine. This is a rare cause of AKI because both kidneys would need to be obstructed to be a full AKI. Etiologies of post-renal: kidney stones, tumors, bladder outlet obstruction, BPH especially, or prostate cancer, and sloughing off of the renal papillae. Clinical manifestations of post-renal: usually asymptomatic, change in urine output, hypertension, and rarely pain. How to diagnose post-renal: increased creatinine, usually associated with bilateral kidney involvement. Ultrasound is often the initial imaging to look for signs of obstruction, and especially hydronephrosis. All the fluids flowing back into the kidney is obstructed on the way out. Depending on the cause of the site of obstruction, cath, CT, MRI, or pylography may be used. Management: remove the obstruction. It's readily reversible if corrected quickly. Next will be intrinsic renal failure. So we'll start with acute interstitial nephritis. So I remember this by AIN, allergic, infection, and NSAIDs. So this is a type of intrinsic acute kidney injury characterized by an inflammatory or allergic response in the interstitium, not the tubules, with sparing of the glomeruli and blood vessels. Etiologies are drug hypersensitivity as most common, 70%, especially with NSAIDs, and selective COX-2 inhibitors, penicillins, sulfa allergies as well, sulfonamides, furosemides, and thiazides, cephalosporins, Cipro, rifampin, and allopurinol. Also, infections are 15%, like strep, Legionella, CMV, EBV, idiopathic and autoimmune, SLE, sarcoid. For clinical manifestations, you'll have fever, eosinophilia, and also a maculopapular rash and arthralgias. For diagnosis, do urinalysis. You'll see white blood cell casts and eosinophiliuria. Eosinophilia via Hansel or Wright stain and increased serum IgE for diagnosis. For management, removing of the offending agent allows for spontaneous recovery, and most recover kidney function in 1 year. So AIN, allergic, infection, and NSAIDs. For ATN, acute tubular necrosis, this is a type of intrinsic renal injury characterized by acute destruction and necrosis of the renal tubules of the nephron itself. Most common type of intrinsic acute kidney injury at about 50%. Importantly, most common type is ATN, acute tubular necrosis. It could be ischemic from prolonged pre-renal azotemia associated with hypotension or hypovolemia. It can also be nephrotoxic due to exogenous or endogenous things. For nephrotoxic, exogenous would be contrast dyes, which would happen immediately. Also aminoglycosides and vancomycin, but these average 5 to 10 days of use for them to take effect. Also cyclosporin and NSAIDs. For endogenous, it could be increase in uric acid precipitation due to not only gout but tumor lysis syndrome. Also myoglobinuria from rhabdomyolysis, lymphoma, leukemia, Bence-Jones proteins, which remember is multiple myeloma as well. So those are those nephrotoxic endogenous ATN. For diagnosis of ATN, you want to do urinalysis, renal tubular epithelial cell casts, and granular muddy brown casts, which are from sloughing off of the tubular cells into the nephrons. So for ATN, epithelial cell casts and granular muddy brown casts. Unlike pre-renal, however, the sodium and water reabsorptive abilities are lost in ATN, leading to a low urine-specific gravity, isothinuria, which is the inability to concentrate the urine. Also a low urine osmolarity, under 500 milliosmoles per kilogram, an increased fractional excretion of sodium over 2%, and an increased urine sodium over 40 milliequivalents per liter. And BUN to creatinine ratio is under 15:1. So management of ATN is to remove the offending agent and IV fluids. There's no proven therapy to benefit ATN, but N-acetylcysteine may be added to normal saline in contrast-induced cases. And remember also N-acetylcysteine is the treatment for an overdose of Tylenol. Furosemide may be used in euvolemia and not urinating. Most patients return to baseline in 7 to 21 days, so it has a relatively good prognosis. Next, acute gomeonephritis and vascular. Microvascular and macrovascular. So microvascular will be TTP, HELP syndrome, and DIC. And macrovascular would be like an aortic aneurysm, renal artery dissection, renal artery or vein thrombosis, malignant hypertension, atheroembolic disease associated with ischemic digits, blue toes, or livedo reticularis, especially in post-cath, CABG, or AAA repair. So for urinalysis, we'll go into this in some more depth. This is the most important non-invasive test regarding the possible etiologies. So depending on the urinary pattern, that can indicate a specific disorder. So if you have red blood cell casts with hematuria and dysmorphic red blood cells, you want to think acute gomeonephritis or vasculitis. If you have muddy brown, granular, or epithelial casts, you want to think ATN, acute tubular necrosis. If there's white blood cell casts or pyuria or free white blood cells, think AIN, acute interstitial nephritis, or pyelonephritis. If there's waxy casts that are acellular with sharp edges, there could be narrow waxy casts, which could be a chronic ATN, or there could be broad waxy casts, which are end-stage renal disease due to tubular dilation. If there's fatty casts and Maltese crosses and oval fat bodies, you want to be thinking of nephrotic. If there's hyaline casts, they're nonspecific, may be seen in normal urine. If there's normal or near normal urinalysis with few cells but no casts, think pre-renal or post-renal azotemia. If there's hematuria and pyuria, excluding red cell casts, think about UTI, AIN, or vasculitis. Hematuria alone or pyuria alone, most commonly due to infection. Okay, so labs for pre-renal versus ATN. So for pre-renal, the creatinine is going to increase slower than 0.3 milligrams per deciliter per day. In ATN, the creatinine increases faster. Fractional excretion of sodium and urinary sodium excretion in pre-renal is going to be low urinary sodium excretion under 20 and an FeNA under 1%. However, for ATN, it's going to be an increased urinary sodium excretion over 40 and a fractional excretion of sodium over 2%. On urinalysis of pre-renal, it could be normal or a high specific gravity due to increased osmolality in the urine. And ATN for urinalysis, we'll see epithelial casts or granular casts and a low specific gravity. So pre-renal response to volume replacement, creatinine rapidly improves with IV fluids. And for ATN, creatinine won't improve much with IV fluids. As for the BUN to creatinine ratio, in pre-renal, BUN is over 20 to 1, and in ATN, it's about 10 to 15 to 1 ratio. To go over some of the casts further, about casts, cellular casts, cells that make into the tubules clump together and take the shape of tubules as they travel through the nephron. The type of cast may be helpful to figure out the possible etiology of the kidney injury. So for ATN, you see epithelial and muddy brown. For AIN, acute interstitial nephritis, you see white blood cell casts. For acute glomerulonephritis, you see red blood cell casts. Okay, so now moving to adult polycystic kidney disease. This is an autosomal dominant disorder due to mutations of either genes, PKD1, which is 85 to 90%, or PKD2, which is 10 to 15%. Multisystemic progressive disorder characterized by formation and enlargement of kidney cysts and cysts in other organs, such as the liver, which is most common, also spleen and pancreas, and also more common for aneurysms like Berry or saccular aneurysms. Pathophysiology, vasopressin stimulates cytogenesis and eventually end-stage renal disease over time. Patients usually present in 30s to 40s, in the adult type anyways. Clinical manifestations, renal, abdominal and flank pain, nephrolithiasis, UTIs and hematuria. Extrarenal manifestations, again cerebral Berry aneurysms in the circle of Willis, which can cause subarachnoid hemorrhages, hepatic cysts, mitral valve prolapse, and colonic diverticula. So anything where any outpouching can occur or breakdown of tissue. Palpable flank masses on physical exam or large palpable kidneys. Also hypertension. For diagnosis, you want to do urinalysis and see hematuria, decreased urine concentrating ability, and proteinuria. And renal ultrasound is the most widely used diagnostic test for polycystic kidney disease. CT or MRI is more sensitive, and genetic testing can be performed when diagnosed. For management, you want to do, if they have simple cysts, you want to observe, periodic reevaluation, ACE inhibitors, and ARBs. If they have multiple cysts, you just want to be supportive, increase fluid intake. Fluids decrease vasopressin, which is what you're having the genesis of those cysts from, which reduces vasopressin-induced cystogenesis and hypertension control. So if anything, it's fluid increase in adult polycystic kidney disease. So next, going to hypophosphatemia versus hyperphosphatemia. So we'll go through etiologies, clinical expression, and management. For hypophosphatemia, this is an increase in urinary phosphate excretion, most commonly primary hyperparathyroidism due to increased calcium, and vitamin D deficiency. So internal phosphorus redistribution, respiratory alkalosis, excessive IV glucose, treatment for DKA, refeeding syndrome in alcoholics due to insulin shifting phosphate intracellularly, just like it does to potassium, and also decreased intestinal absorption of phosphate due to antacids and phosphate binders. Clinically, for hypophosphatemia, you'll have diffuse muscle weakness, flaccid paralysis, and remember, this is due to decreased ATP, where that's adenosine triphosphate, so we need the phosphate in order to contract the muscles in the first place. Management is treat the underlying cause, phosphate repletion. If symptomatic or serum phosphate is under 2, you want to do potassium phosphate or sodium phosphate. Next, for hyperphosphatemia, etiologies, clinical expression, and management. Hyperphosphatemia is usually due to renal failure, which is most common, which will lead to decreased calcium, increased phosphate, as they usually go inverse to each other, and increased intact parathyroid hormone. Primary hypoparathyroidism, decreased calcium, increased phosphate, decreased intact PTH. And vitamin D intoxication, increased calcium, increased phosphate, decreased intact parathyroid hormone. Also for hyperphos, you can have iatrogenic and DKA, also rhabdo and tumor lysis. So remember, phosphate is a part of the cells itself, so any syndrome where cells are breaking down, we can have an increase in phosphate, such as in tumor lysis or rhabdo. Clinical, soft tissue calcifications for hyperphos, and mostly asymptomatic, but some can have heart blocks. Management is management of the renal failure. You want to do phosphate binders, calcium acetate, which is phoslo, or calcium carbonate, or sevelamer as well. Decreased dietary phosphate, dairy products, dark colas, hydration, and acetazolamide can help. Next, we'll move into chronic kidney disease and end-stage renal disease. So chronic kidney disease is a progressive functional decline in greater than or equal to 3 months to years, as evidenced by proteinuria, abnormal urine sediments, abnormal serum to urine chemistries, abnormal imaging studies, inability to buffer the pH, inability to make urine, inability to excrete nitrogenous waste, and decreased synthesis of vitamin D and erythropoietin. So chronic kidney disease staging, at stage 0, these are just at-risk patients like diabetics, hypertension, chronic NSAID use as well, age over 60, SLE, status post-kidney transplant, family history of kidney disease, and a normal GFR with normal urine and normal albuminuria. Stage 1 will be kidney damage with a normal GFR, or over 90, or kidney damage with proteinuria, abnormal urinalysis, serum or imaging, albuminuria, which will be an albumin to creatinine ratio under 30 milligrams per gram per day. An A2 for ACR is 30 to 300, and an A3 for ACR is over 300 milligrams per gram a day of albumin to creatinine ratio. Stage 2 chronic kidney disease is 89 to 60, so 90 to 60. And then stage 3 is 60 to 30. Stage 3A is 60 to 45. And stage 3B is 45 to 30. And then stage 4, 30 to 15. Stage 5 is considered end stage, and that's under 15, which is also characteristic of uremia requiring dialysis or transplant. And remember, normal GFR is 120 to 130. Etiologies of CKD: diabetes is the most common cause of end-stage renal disease, and hypertension is the second most common. Also glomerulonephritis, polycystic kidney disease, and rapidly progressive glomerulonephritis. Clinical manifestations: uremia, nausea, vomiting, fatigue, malaise, metallic taste, hiccups, altered mentation, and remember, hiccups is from hyponatremia actually. Altered mentation, irritability, muscle cramps and easy bruising, fluid overload, encephalopathy, or pericarditis. For a diagnosis, albumin to creatinine ratio is best. You'll see proteinuria, the single best indicator of disease progression. This is done by the SPOT urine albumin to urinary creatinine ratio, the ACR, preferred over 24 hours of urine collection. SPOT urine test estimates the grams of protein lost per day. There's increased BUN in creatinine, and on urinalysis, abnormal sediment may be seen. They may have red blood cell casts, white blood cell casts, and importantly, broad waxy casts seen in end-stage renal disease, taking the shape of dilation and damaged tubules. Also urine dipstick. So don't forget the broad waxy casts in end-stage renal disease. For estimated GFR, the CKD epi is the most accurate. Also the MDRD and the Cockcroft-Gault used for creatinine clearance. And this is used for renally dosing medications also. Renal ultrasound: small kidneys are classic for chronic kidney disease, whereas there'd be large kidneys in diabetic nephropathy or polycystic kidney disease. Remember, diabetic nephropathy and those mesangial depositions increase the size of the kidney as a whole. And for small kidneys, for CKD, the kidneys are atrophied because they've been destroyed over a long period of time. For management, hypertension, the blood pressure goal is under 140/90. ACE and ARBs are in early disease. Proteinuria, ACE and ARBs again should be used. Diabetes control, A1C under 7% is your goal. Hyperlipidemia, LDLs under 100, triglycerides under 150, and HDLs over 50. Also know about renal osteodystrophy and how to manage that. Low calcium plus high phosphate. This is managed by active vitamin D, calcitriol, plus phosphate binders like calcium acetate, calcium carbonate, and sevelamer used if both calcium and phosphate are elevated. So you want to bind the phosphate, and calcitriol is the third step in vitamin D synthesis, which is done by the kidneys, so it can no longer synthesize vitamin D, so we need to supplement with that. Hypocalcemia and osteomalacia: replace vitamin D and calcium. Dialysis, end-stage renal, acidosis, electrolyte imbalances, ingestion or overload, volume, and uremia. Renal transplant for some end-stage renal disease. Dialysis is indicated if a GFR is 10 or less, or a serum creatinine is over 8. In diabetics, if the GFR is 15 or less, or the serum creatinine is over 6, there's indication. Next, moving to renal osteodystrophy. This is a bone disorder, like osteitis fibrosa cystica and osteomalacia associated with CKD. Pathophysiology: the failing kidneys do not eliminate phosphate properly, leading to an increased phosphate and simultaneously poorly synthesized vitamin D. This leads to hypocalcemia and compensatory increase in PTH, parathyroid hormone, which is a secondary hyperparathyroidism, and decreased bone mineralization by osteoclast activity, breaking down that bone. PTH pulls the calcium from the bone. Clinical manifestations of osteodystrophy: bone and proximal muscle pain in the context of uremia. So not just bone and muscle pain, but it must be in the context of uremia. Also pathologic fractures and chondrocalcinosis, the calcium in the cartilage. For diagnosis, hypocalcemia plus increased phosphate plus increased intact PTH, which is secondary hyperparathyroidism. Also an increased alk-phos, importantly. Vitamin D levels may vary. Radiographs, you have osteitis fibrosa cystica, which Hallmark is periosteal erosions and bony cysts with thin trabeculum and cortex, and the classic salt and pepper appearance of the skull, which is a punctate trabecular bone reabsorption in the skull. On biopsy, cystic brown tumors describing the appearance of hemosiderin, not an actual tumor. For management, phosphate binders is important. Decrease phosphate and add calcium. Calcium carbonate, calcium acetate. Sevelamer is used in both calcium and phosphate levels are elevated. Phosphate goals under 5.5. For supplements, you want to add vitamin D, calcitriol, and calcium, and you can do cinacalcet, which mimics the parathyroid hormone receptors of calcium, making it want to lower the calcium. So for classic bone diseases, we're going to go through some of the diseases and some of the related labs. So for hypoparathyroidism, you have a decreased calcium, decreased phosphate, decreased PTH, but an increased ALK-Phos. For primary hyperparathyroidism, you have increased calcium, decreased phosphate, increased PTH, increased ALK-Phos. For secondary hyperparathyroidism associated with renal osteodystrophy, you have a decreased calcium, an increased phosphate, an increased PTH, and an increased ALK-Phos. For osteomalacia due to vitamin D deficiency, you have a decreased calcium, you have a decreased phosphate, PTH will be increased, and ALK-Phos will be increased. For osteoporosis, calcium, phosphate, PTH, and ALK-Phos are all normal. For Paget's disease of the bone, normal calcium, normal phosphate, normal PTH, but extremely elevated ALK-Phos for Paget's disease of the bone. Next will be horseshoe kidney. This is fusion of one pole of each kidney, most commonly fused at the lower poles. The fusion may be associated with entrapment of the inferior renal artery. Risk factors may be associated with other congenital urologic abnormalities like uretopelvic junction obstruction, most commonly, and vesiculourethral reflux, or genital abnormalities like a bicornuate or septate uterus, as well as cryptorchidism and hypospadias. May also be seen in Turner syndrome and trisomy 13, 18, and 21. Complications of horseshoe kidney: urinary stasis leads to increased risk for pyelo and kidney stones, increased risk for renal malignancies, renal cell carcinoma, most commonly, 45% of tumors, also transitional cell cancer, and Wilms tumor. Clinical manifestations of horseshoe kidney: majority are asymptomatic, often seen as an incidental finding. Hematuria or pain due to infection or obstruction, renal calculi in 20%. Also hydronephrosis due to vesiculourethral reflux or uretopelvic junction obstruction. Diagnosis of horseshoe kidney: ultrasound to detect horseshoe kidneys and evaluate for hydro. CT urography is the best initial test to evaluate anatomy and relative renal function, CT urography. Voiding cystourethrogram to detect vesiculourethral reflux, and radionuclide renal scan can differentiate from a true obstruction from passively dilated systems. Management: majority require no management. UTI or hydronephrosis need to be treated. Patient with obstruction should be referred to urology. Hydronephrosis is next. This is a urinary tract obstruction leading to dilatation of the collecting system in one or both kidneys. Pathophys of hydronephrosis, which is characterized by an obstruction of the passage of urine. Etiologies: kidney stones, ureteral, tumors, bladder outlet obstruction, benign prostatic hypertrophy or prostate cancer, or sloughing off of the renal papillae. Clinical manifestations: usually asymptomatic, change in urine output, hypertension, hematuria, and rarely pain. Diagnosis: urinalysis, often benign but may show hematuria. Labs may have an increased serum creatinine. Ultrasound is the imaging study of choice, importantly for hydronephrosis. Ultrasound. You'll see dilation of the collecting system in one or both kidneys. CT scan indicated in those with flank pain and suspected nephrolithiasis in patients whom visualization of the ureters is needed. Management: removal of the obstruction. Renovascular hypertension or renal artery stenosis. Hypertension secondary to renal artery stenosis in one or both kidneys. This is the most common cause of secondary hypertension. And you want to think about secondary hypertension when they're refractory to 3 meds and lifestyle changes. Pathophysiology of renal vascular hypertension is decreased renal blood flow leads to an activation of the renin-angiotensin-aldosterone system. So remember the JGA, the juxtaglomerular apparatus, which is the macula densa cells, they're no longer touching the glomerulus, thus indicates there's a decrease in flow, and they secrete renin in response to increase the blood pressure. Etiologies, atherosclerosis is the most common in the elderly. Also fibromuscular dysplasia, which is most common cause in women under 50 years old. Clinical manifestations, suspect in patients with a headache and hypertension under 20 years or over 50 years, severe hypertension, hypertension resistant to 3 or more drugs, abdominal bruit, or a patient that develops acute kidney injury after the initiation of an ACE inhibitor therapy. Diagnosis. Diagnostics testing is only indicated if a corrective measure is to be performed if clinically relevant disease is discovered. Non-invasive options include CT angiography, MR angiography, or duplex ultrasound. Renal catheter arteriography, which is definitive and gold standard. That's renal catheter arteriography, gold standard. This is revascularization, which can be performed during the same procedure if the stenosis is present. This is not used in patients with renal failure. Surgical management is revascularization, which is definitive, either by angioplasty or bypass. Angioplasty with a stent is performed if the creatinine is over 4, or if the increased creatinine with ACE inhibitor treatment, or an over 80% stenosis, is when you do surgically an angioplasty with stent for renovascular hypertension. Medical management, ACE or ARBs can be used, which inhibits aldosterone 2-mediated vasoconstriction. However, ACE and ARBs are contraindicated if there is bilateral stenosis or in a patient with a solitary kidney, because they can lead to acute kidney injury in these patients, as they markedly reduce renal blood flow and GFR, because they dilate the efferent arteriole after the glomerulus. You can also do add-on therapy to those ACEs and ARBs with thiazides or long-acting calcium channel blockers. Next, we'll go into hyperkalemia. Hyperkalemia, you need to know about the etiologies. One is pseudo-hypokalemia. This is due to hemolysis and venipuncture, especially in the patient if the patient clenches their fist during the venipuncture, or the tourniquet is left on for too long, leading to lab error from a lysis of cells. And remember, cells are bags of potassium, so they rapidly increase the potassium. Suspect asymptomatic patients with an elevated potassium, or thrombocytosis, or leukocytosis, and no EKG changes. Can leak out into the lab specimen itself. Also, decreased renal potassium excretion, acute or chronic renal failure, especially end stage, hypoaldosteronism, primary adrenal insufficiency, Addison's disease, drugs that block aldosterone such as ACE, ARBs, spironolactone, and eplerenone, and also medications, K+ supplementation, NSAIDs, cyclosporin, heparin, trimethoprim, other potassium-sparing diuretics like amiloride, triamterene, beta blockers, and digoxin. So remember, for digoxin, it leads to hyperkalemia, but it's because of a hypokalemia. Tissue destruction also as a cause for hyperkalemia, as it releases potassium into the cells, or from the cells rather, due to tissue destruction. Rhabdo, Burns, and tumor lysis syndrome, importantly. And also K+ extracellular redistribution, especially during a metabolic acidosis like DKA. And so remember, all those ketones and all the glucose are in the extracellular fluid, and so when glucose gets taken up into the cell, it also brings potassium with it. So with the lack of uptake, we're going to have a huge increase in hyperkalemia. Insulin deficiency as well, for that same reason. Also catabolic states when you're breaking down the cells as well. And mannitol. Clinical manifestations, hyperkalemia affects muscle contraction and cardiac conduction, but it does not cause seizures. Neuromuscular, weakness, progressive ascending, fatigue, paresthesias and paralysis. Cardiovascular, palpitations, cardiac arrhythmias, which are potentially life-threatening arrhythmias. GI, abdominal distension, ileus, which paralyzes the intestinal muscles. For diagnosis, a serum potassium over 5 milliequivalents per liter. Also, you need to check the lab for potential causes, like glucose, hyperglycemia, bicarb acidosis, CBC for hemolysis, and a creatinine kinase for rhabdo. EKG will tall peak T waves, earliest manifestation, QT interval shortening, a wide QRS, and a prolonged PR interval, P wave flattening, and a sine wave followed by arrhythmias. So those 5 findings are prolonged PR interval, wide QRS, sine waves, definitely a peak T wave, and QT shortening. Management, mild or no EKG changes. You want to recheck the K+ levels to rule out hemolysis from venipuncture. Also pseudo-hyper K, repeat the sample. Management if significantly elevated or EKG changes. The most important step is IV calcium gluconate or calcium chloride to stabilize the myocardium. It does not lower the levels of potassium, but it does protect against arrhythmias. So you also want to treat the underlying cause, potassium-lowering agents. So how it's remembered is a C, a big K drop. So C, BIG, KD. C, calcium gluconate, which stabilizes the membranes, brings its threshold potential more positive, so it's closer to the pathologic K+ increase. Next, bicarb and beta-2s, short-acting beta agonists. So beta blockers will increase potassium, especially the non-selective ones. I, insulin, as it pushes the potassium into the cell with the glucose. G, glucose itself. K, K-exalate, which really isn't used anymore because it takes 2 to 3 days to work. Drop, which is diuretics and dialysis. Diuretics, Lasix especially, and dialysis, of course. So that's C, big K drop to lower the levels of hyperkalemia. Next, hypokalemia. Etiologies of hypokalemia are urinary or GI losses, especially diarrhea and vomiting, laxative abuse, diuretic therapy, including loop and thiazides, and carbonic anhydrase inhibitors like acetazolamide. Increased mineralocorticoid activity, such as hyperaldosteronism as well, which increased sodium decreases potassium. Also importantly, increased intracellular potassium shift, such as in metabolic alkalosis, where hydrogen ions leave the cell in exchange for potassium entering the cell. Medications, everything that we see in big K drop can overshoot and become hypokalemic as well. So medications like the insulin therapy, beta-2 agonists, SABAs, chloroquine, vitamin B12, and amphotericin B, and also hypothermia. Hypomagnesemia, low magnesium opens magnesium-gated dependent potassium channels, spilling potassium into the urine. So if we try to correct the potassium and then it doesn't correct, we want to look at the magnesium secondarily. Type 1, also classic distal, and type 2, proximal, renal tubular acidosis is also a cause. Hyperthyroidism, also genetic defects. Clinical manifestations, hypo-K affects muscle contraction and cardiac conduction. It does not cause seizures. Neuromuscular manifestations, severe muscle weakness, paralysis, decreased deep tendon reflexes, ileus, nausea and vomiting. So importantly, muscle weakness, paralysis, decreased deep tendon reflexes, and ileus. Cardiovascular, palpitations and arrhythmias. Polyuria causes nephrogenic DI, may cause rhabdomyoglobinuria, and remember, it may predispose those on digoxin to digoxin toxicity and hyperkalemia. Diagnosis, serum electrolytes, including magnesium, very important. On EKG, you see T-wave flattening is the earliest sign, followed by prominent U waves and PVCs and ST depressions. Management, oral potassium chloride is the mainstay. And for severe, you want to do slow IV potassium chloride, usually 10 to 20 milliequivalents per liter per hour. And peripheral infusions over 40 milliequivalents per liter per hour may lead to burning, sclerosis, and phlebitis. It may be difficult to replete potassium in patients with concurrent hypomagnesemia without magnesium repletion. Next, into hypermagnesemia. So, renal insufficiency, hypermagnesemia, is rare in the absence of renal insufficiency. Iatrogenic excess of IV magnesium administration, such as in management of asthma, preeclampsia, eclampsia, torsades as well, and arrhythmias. Lithium can cause hypermag adrenal insufficiency and milk alkali syndrome, ingestion of magnesium-containing substances like vitamins and antacids, clinical manifestations of hypermagnesemia, decreased deep tendon reflexes are the first sign, nausea, vomiting, skin flushing, weakness, lightheadedness, altered mental status and ileus due to that GI hypomotility, somnolence, and respiratory depression. Increased magnesium levels have calcium channel blockade-like effects, conduction defects, bradycardia, and hypotension that may be refractory to fluids and pressors. For diagnosis, serum electrolyte levels, EKG, may be similar to hypomagnesemia, prolonged QT or PR interval, and a wide QRS complex. For management, mild in the presence of normal renal function, cessation of magnesium-2 containing sources will normalize magnesium levels, so discontinue the offending agent. If it's severe hypermag, IV calcium gluconate stabilizes the cardiac membranes in patients with EKG changes. Then you want to do IV fluids and furosemide to enhance magnesium excretion. Dialysis for severe or refractory cases. For hypomagnesemia, for etiologies, you want to look at GI losses like malabsorption, chronic alcoholism, celiacs, small bowel bypass, prolonged diarrhea, vomiting or laxatives, renal losses, thiazides or loops, endocrine, hypoparathyroidism, hyperaldosteronism, loses potassium too. Medications, PPIs like omeprazole, for over 5 years can lead to that hypomag, amphotericin B, cisplatin, cyclosporin, and aminoglycosides. Hypomag clinical manifestations, neuromuscular hyperexcitability, similar to hypocalcemia. Tetany, increased deep tendon reflexes, one of the first clinical signs. Again, Trousseau and Chvostek sign. Tremor, muscle cramps, weakness and seizures. Altered mental status, lethargy and vertigo. Cardiovascular complications of hypomag, arrhythmias and palpitations. And for psychiatric, dementia or psychosis. So the clinical manifestations are similar to a hypocalcemia in hypomag. Diagnosis, serum electrolytes, prolonged QT, just like in hypocalcemia, prolonged PR, QRS widening, importantly, which can lead to torsades, atrial or ventricular fibrillation, ventricular tachycardia. Management is oral magnesium oxide, or if you have severe or torsades, it's IV magnesium sulfate or chloride. Mag-sulf is preferred in torsade. Hypocalcemia or hypokalemia may be induced by hypomagnesemia and may be refractory to correction until magnesium is repleted. So again, always checking that magnesium level. Next, into hypernatremia. This is an increased serum sodium over 145 milliequivalents per liter due to increased free water loss, hypotonic fluid loss, or hypertonic sodium gain, which is iatrogenic. Etiologies could be diarrhea, diuretics, sweating, burns, fever, insensible losses, and diabetes insipidus. Pathophysiology, sustained hypernatremia seen when appropriate water intake is not possible or it's impaired, such as in infants, elderly, or debilitated patients, or an impaired thirst mechanism. Clinical manifestations of hypernatremia, neurologic symptoms are primarily due to the shrinkage of the brain cells from dehydration. This is as thirst is the most common symptom, confusion, lethargy, disorientation, fever, fatigue, nausea, vomiting, muscle weakness, seizures, coma, brain damage. Symptoms occur with a varying degree of rapidity of hypernatremia. Physical exam of hypernatremia, dehydration leads to dry mouth or mucous membranes, decreased skin turgor, tachycardia or hypotension, a doughy skin in kids, remember, for hypernatremia. Diagnosis is by serum studies, serum sodium, urine osmolarity, serum osmolarity, assess volume status, and hypernatremia always is associated with hyperosmolality, almost always. Hypernatremia, hyperosmolality, as we're only losing basically free H2O. For urine studies, urine sodium is elevated in renal loss or decreased if extrarenal losses. Urine osmolality is increased, concentrated, if extrarenal, or decreased, dilute urine, if diabetes insipidus. Management, hypotonic fluids like pure water, orally, D5W, 0.45 normal saline, or 0.2 normal saline, or 0.2 saline rather. Preferred route is oral or feeding tube. Isotonic fluids if hypovolemic. Normal saline or lactated ringers. Then switch to hypotonic fluids to correct the hyponatremia once volume is repleted. Rapid correction over 0.5 milliequivalents per liter per hour can result in cerebral edema. So the shift in swelling due to the gradient from dehydrated hypernatremia neurons to swell hyponatremia. Serum sodium under 135 milliequivalents per liter due to increased free water. The type is determined by serum osmolality and volume status. Clinically significant hyponatremia is hypotonic hyponatremia. So importantly, clinically significant hyponatremia is a hypotonic hyponatremia. Hypertonic hyponatremia is due to hyperglycemia or mannitol infusion. An isotonic hyponatremia is a lab error due to hyperproteinemia or hypertriglyceridemia, if that's an isotonic hyponatremia. Importantly, like we said, hypotonic hyponatremia can have many causes, and this is clinically significant hyponatremia. 3 types are determined by volume status. So this is under hypotonic hyponatremia. It can also be hypovolemic due to renal volume loss, such as diuretics, ACE inhibitors, or extrarenal volume loss, like GI loss, such as diarrhea, vomiting, burns, fever, or pancreatitis. For isovolemic hypotonic hyponatremia, the cause is SIADH most prominently. Also hypothyroidism, adrenal insufficiency, a reset to the hypothalamic osmostat, water intoxication, which is primary polydipsia, also beer potomania. For hypervolemic hypotonic hyponatremia, these are in edematous states, such as CHF, nephrotic, and cirrhosis. Clinical manifestations overall are neurologic symptoms, primarily due to cerebral edema, confusion, lethargy, disorientation, fatigue, nausea, vomiting, muscle cramps. Symptoms vary with degree and rapidity of hyponatremia. For diagnosis, you need to take 3 steps to help determine the cause and effective treatment. Step 1, measure the serum sodium. Step 2, measure the serum osmolality. Step 3, assess the volume status overall, if hypotonic, especially if decreased osmolality. Management, in general, with the exception of severe causes, correct the serum sodium at greater than 0.5 milliequivalents per liter per hour can lead to central pontine myelinolysis, demyelination, which is not what you want to do, leading to permanent neurologic damage. When treating hyponatremia, it is important to consider volume status, degree and severity of symptoms, and duration and magnitude of the hyponatremia. There are 4 treatments you need to know. Isovolemic hypotonic hyponatremia, you just want to do water restriction and treat the underlying cause, such as SIADH. If it's hypovolemic hypotonic hyponatremia, you want to do volume replacement with normal saline. Hypervolemic hypotonic hyponatremia, this is volume removal as a treatment, diuretics, sodium, and water restriction, treat the underlying cause. Severe hyponatremia, where the patient is obtunded with coma or seizures, you want to do IV hypertonic saline plus furosemide. Regardless of the volume status, stabilization of the patient is paramount if severe. And so just to go over each category and what you might see for each of them. For hypervolemia, you might see peripheral or presacral edema, pulmonary edema, JVD, hypertension, decreased hematocrit, decreased serum protein, and decreased BUN to creatinine ratio. For hypovolemia overall, they'll have poor skin turgor, dry mucous membranes, flat neck veins, hypotension, increased hematocrit, increased serum protein, and increased BUN to creatinine ratio over 20:1. And lastly, isovolemic. You'll have the absence of signs of hyper or hypovolemia. So now going through hyponatremia and hypernatremia in an algorithmic fashion here. So first, for hyponatremia, we want to look at the serum osmolality. It can be low, as in hypotonic hyponatremia, which then we'll further assess. It can be normal, which will be a lab error due to increased proteins and increased triglycerides, or it could be high serum osmolality, due to hyperglycemia or mannitol. So if it's low serum osmolality and it's hypotonic hyponatremia, you want to also look at the extracellular volume and see if it's low volume, hypovolemia, normal isovolemia, or high hypervolemia. So with a hypotonic hyponatremia that's also hypovolemic, we need to look at if it's a renal loss, which the urinary sodium will be over 20, or if it's an extrarenal loss, where the urinary sodium will be under 10 and the fractional excretion of sodium under 1. So if it's a renal loss, it's likely diuretics, or renal tubular acidosis, or hypoaldosteronism. Or if it's an extrarenal loss, that's like bleeding, burns, GI, nausea, vomiting, pancreatitis. And the management is normal saline, just correct the volume. If it's a hypotonic hyponatremia with normal isovolemia, you want to think of SIADH, and the management is water restriction. If it's high hypervolemia with, again, a hypotonic hyponatremia, you want to look and see if the urinary sodium is under 20, and that will be a CHF, cirrhosis, or nephrosis, or a urinary sodium over 20, acute and chronic renal disease. Now hypernatremia, and if you have an extracellular fluid volume that's hypovolemic, you want to again look at the extrarenal losses. You're losing basically pure water, so sweating, respiratory loss, GI loss, dehydration, or renal loss, severe hyperglycemia, or osmotic diuretics. If you have a hypernatremic with an isovolemic, think diabetes insipidus. And remember, SIADH in hyponatremia and diabetes insipidus in hypernatremia. But it's isovolemic hypernatremia, you want to think of diabetes insipidus. Hypervolemic hypernatremia, think about hypertonic saline and mineralocorticoid excess. And remember, hypernatremia is associated with hyperosmolality, so you can skip right to volume status. So next, we'll go into different types of acid-base disturbances. The lungs and the kidneys we'll start with. Lungs, CO2 regulation via respiratory rate, minutes to hours. Acidosis stimulates increased respiration to blow off the excess CO2. Alkalosis depresses respiration to retain CO2. The kidneys, their goal is to generate new bicarb by eliminating H+ or protons from the body. Adds 1 bicarb for every H+ secreted. Reabsorbs virtually all the filtered HCO3 at the proximal tubule. Increase in bicarb reabsorption seen with increase in PCO2, hypovolemia, and hypokalemia. So a few mnemonics to know are anion gap metabolic acidosis, which is mud pilers. That's methanol, uremia, DKA, propylene glycol, isoniazid or infection, lactic acidosis, ethylene glycol, and rhabdo or renal failure and salicylates. That's mud pilers. So that's too much acid or too little bicarb. For non-GAP metabolic acidosis, it's hard ups, which is hyperalimentation, a speedy digestion, acetazolamide, renal tubular acidosis, diarrhea, ureteropelvic shunt, post-hypocapnia, and spironolactone. Anion gap metabolic acidosis, or a high anion gap metabolic acidosis, is the acid in the blood dissociates into H+ and an ion not routinely measured. The H+ is buffered by the bicarb, leaving an unmeasured anion to accumulate in the serum, creating the anion gap. Normal gap metabolic acidosis, which is hyperchloremic. Normal gap acidosis is a loss of bicarb that is replaced by chloride, a measured anion. So there is no change in the anion gap, but there is an accumulation of chloride concentration. In other cases, diarrhea, type 2 renal tubular acidosis, there's a loss of sodium bicarb and the kidney tries to preserve the volume by retaining the sodium chloride. Also, metabolic alkalosis now we'll move to. This is increase of bicarb in the serum with an increase of pH, requiring and generating maintenance factors. Etiologies, generating factors, are a loss of bicarb from GI tracts or kidneys, vomiting or NG tube suction, loss of gastric HCl that is perpetuated by the extracellular volume loss depletion, chronic diarrhea, also perpetuated by volume depletion, and loop diuretics. Metabolic alkalosis can also be caused by exogenous alkali or contraction alkalosis. For instance, a diuresis leads to excretion of bicarb, poor fluid, contracts around the stable level of bicarb, increased bicarb concentration. Or post-hypercapnia, rapid correction of respiratory hypercapnia, mechanical ventilation for instance, leads to a transient excess of bicarb until the kidneys can excrete it. So remember that the lungs compensate much quicker than the kidneys can. So if you're already starting to compensate or compensating for a while, the kidneys can't just quickly shut off the bicarb, but the lungs quickly stop producing that excess CO2 when you're hyperventilating. Next, respiratory acidosis, anything that decreases respiration, so it holds onto the CO2. Acute respiratory failure, like CNS depression, in opioids, sedatives, trauma, cardiopulmonary arrest, and pneumonia. Chronic respiratory failure in COPD, obesity, neuromuscular disorders like myasthenia gravis or Guillain-Barré syndrome. Respiratory alkalosis, principally hyperventilation. CNS disorders, pain, anxiety, salicylates, progesterone, pregnancy, hepatic failure. Stimulation of pulmonary receptors like pneumonia and asthma. Next, we'll move to renal cell carcinoma. This is a tumor of the proximal convoluted renal tubule cells. They are very metabolically active cells, so they are the most prone to dysplasia. So that's the proximal convoluted tubule renal cells, most metabolically active in the PCT. 95% of primary tumors originating in the kidney are clear cell. Clear cell is most common histologic pattern, characterized by lack of warning signs, variable presentations, and resistance to chemo and radiation. Risk factors are smoking, hypertension, obesity, men, dialysis, and cadmium or industrial exposure. Classic triad of hematuria, flank or abdominal pain, and a palpable abdominal mass. Important. Hematuria, flank or abdominal pain, and a palpable abdominal mass. The triad is classically seen in locally advanced disease. Hypertension and hypercalcemia are common. Left-sided varicocele if the tumor blocks the left testicle vein drainage, importantly. Left-sided varicocele. Mets, cannonball metastases to the lungs, most common site for metastasis, as the cancer searches for the highest O2 concentrated tissue. CT scan usually the initial test of choice. You can also do a renal ultrasound, MRI, and erythrocytosis is often present. Due to increased red blood cells, increased erythropoietin from those kidney cells. Management 1 through 3, you want to do a radical nephrectomy and partial nephrectomy in patients with bilateral involvement of the solitary kidney or an option for earlier disease. And lastly, for this chapter, nephroblastoma, which is a Wilms tumor. Most commonly seen in children within the first 5 years of life. Most common renal malignancy in children. Most common abdominal mass in children. The risk factors may be associated with other GU abnormalities like cryptorchidism, hypospadias, and horseshoe kidney. The mnemonic is WAGR, W-A-G-R, Wilms tumor, aniridia, genitourinary malformations, and retardation, mental retardation, associated with chromosome 11 abnormalities. Clinical manifestations, palpable abdominal mass is the most common manifestation. The mass doesn't cross the midline, unlike a neuroblastoma. So differentiating neuroblastoma from nephroblastoma, think nephro is a nephron, which is in the kidney, which is only on one side. So the mass does not cross the midline, it stays on one side, and a neuroblastoma does cross the midline. Also note hematuria, constipation, abdominal pain, nausea, vomiting, hypertension. Diagnosis, abdominal ultrasound is the best initial test. CT with contrast or MRI is the most accurate test. Lung is the most common site for METs, so chest imaging is usually required. Managed by total nephrectomy followed by chemo. It has a good cure rate at 80 to 90%. and a partial nephrectomy if bilateral involvement. Post-surgery radiation if it extends beyond the renal capsule, or if there's pulmonary mets or a large tumor. And that'll conclude the renal system for Pance Prep Pearls.